Hi everyone, can you all hear me, yeah? That's great, okay. So I'm going to talk about something very, very different. So I'm talking about evidence into practice. So we're going to talk a little bit about blood pressure first, and many of you will be familiar with this, but there are some non-medical people in the audience, so I'll talk a little bit about this. So high blood pressure is a major reversible cause of stroke, MI, and renal disease. And more than 1 in 4 adults have high blood pressure. And measuring blood pressure is the second commonest reason for attending primary care. There are 1.2 million appointments in general practice every year for nothing else but checking blood pressure. Okay, that's the only thing that happens. And there are many millions more as part of routine care. So there are a lot of problems with measuring blood pressure. So measurements taken in GP surgeries are inaccurate compared with ambulatory blood pressure monitoring and home monitoring. And they're actually a very poor predictor of future pathology. Around about 15 to 20% of people who thought to have high blood pressure have a thing called white coat hypertension, where the blood pressure in the surgery is raised, but at home it's normal. And there's a small number that have concealed hypertension who have high blood pressure at home, but not in the surgery. 30% of people who are known to have high blood pressure do not have controlled blood pressure. And it's getting worse, okay? As the population ages, blood pressure is something that increases with age, so the numbers of people with high blood pressure are increasing. And it's an increasingly unhealthy population, as we've got Homer again. And if you look at these conditions, stroke, angina, heart attack, and diabetes, they all involve blood pressure measurement as well. So this problem of the numbers of measurements that's going to take place in the UK is increasing, and in the next 10 to 15 years, the number will double. So how do we cope with this? So there's been a policy drive towards self-monitoring and self-care over the years. And self-monitoring of blood pressure is roughly as effective as routine care, but patients feel quite insecure if they're left alone to do nothing but just self-monitor. And they tend to consult doctors and nurses anyway, so it does not reduce workload having people measuring their own blood pressure at home. So there's been this drive then towards telemetrically supported supervised self-monitoring. This is how it works. So the patient takes their blood pressure at home, and that can be sent by a variety of means. This says SMS here, but it could be a whole variety of means to a remote server. An automatic response is sent back to the patient telling them that their blood pressure is controlled or not controlled, or that it's getting better and to keep on taking their drugs. And in the past, what we used to do is a nurse would check this website every 1 to 2 weeks to check that the patient had actually carried out these instructions, and then contact the patient. And we checked this out in a randomized controlled trial. So we did a randomized controlled trial in Lothian, 401 people with uncontrolled blood pressure, and we demonstrated a 4 millimeter drop in blood pressure compared with control. And that was measured accurately by ambulatory blood pressure monitoring. And that doesn't seem like a very large drop, but if that were carried out to the full population, it would reduce the stroke rate by 15%, reduce the MI rate by 10%. We did further randomized controlled trials in people who had diabetes and people who had had stroke, and they both showed similar falls. And systematic reviews around the world and patient-level meta-analysis confirm that amount of control if you've got telemonitoring linked with clinicians who are following it up, and that's really very important. But the immediate impact on resources was maybe not quite so good. So we saw here that, in fact, it increased general practice surgery attendance slightly, and nurse surgery attendance as well. And so we did a qualitative study with clinicians to find out why did it increase attendances. So clinicians had to log on to a separate website to see results, and the problem is that doctors, when they've only got 10 minutes, they can't be bothered remembering logons or passwords, and so it's so much easier just to tell the patient to come in, and they'll just check it out. So even though they've got 20 blood pressures clearly showing that this patient has uncontrolled blood pressure, the patient's told to come in and have a single blood pressure checked in the surgery. So many GPs didn't bother to look at this at all, potentially reducing the effect. They suggested that anything that integrated this into their normal working practice would make it easier to manage. And we all know that technology takes a little bit of time to embed. People have, they get used to doing things a certain way. But doctors and nurses were of the view that once this was established, it would save them time. So we wanted to implement this at scale, and the major challenge facing telehealth, clinicians are really, really busy. It's hard to get them to do new things. It has to fit with their current work patterns. It must be seen to benefit patients and the clinicians. It has to be intuitive and easy to use. And you need time and support for the introduction of these things and time to bed in when you eventually evaluate it. So we knew it worked because we had randomized controlled trials that worked. So people didn't need to be persuaded of that. But they needed to be persuaded that it wasn't going to take up a lot of extra time. Because when I was talking to GPs about this, they were saying, if you're saying to me that my patients are going to get better as a result of this, that's well and good. But you tell me, what am I going to have to stop doing to do this? Because they just didn't have any additional time at all. So we introduced Scale-Up BP, and this is a little bit different. So this involves a very simple system based on text reminders to patients, and then they text in their blood pressures. Any mobile phone can be used, it uploads to our website. But what's new about this is that NHS Lothian can extract the data from this website every 1 month, every 3 months, every 6 months, and it's converted into a report which is sent by a docman. Now that's the normal information handling system that GPs use in the surgery, so how they get their lab results, their hospital letters, all come through this system, and so does this. So they didn't need to log on. So the practice nurse could have a look at this, or the GP, and note any problems, and the patient is phoned to check compliance, or if necessary, change the medication. But the website was available if people wanted to go and see a more up-to-date list of blood pressures. And this is the sort of thing that they got. So you can see this, this is what the GP gets, and it's really very clear. And you've got blood pressures are displayed graphically and in the tabular form, and it's actually very, very plain whether you've actually reached the average blood pressure or not, and a clear recommendation of what to do next. Very, very hard to ignore this. So the reaction from general practice was really good. I sent out this very simple but upbeat letter just along the lines of free yourself from the chains of sphygmomanometers and stuff like that. And almost immediately got responses because people really got this. They actually got the idea that this would work. 23 responses with practice for 24 hours. We used to have such trouble getting people to do this. 40 expressions of interest in a week, and we've got more than 30. This is out of date, this slide. More than half the practices in Lothian have signed up. We got 7 practices to help us develop this and adopt this and develop the technology over the next few weeks. And that was really important to have these small number of practices that are really interested. These champions are important in implementing stuff. So the progress, we were slow in the early stages. Now got 1,700 people or more signed up in Lothian. It has dramatically increased. The main drawback was finding the need for support over transition. It takes a little bit of time to put people on the system for the first time. After that, it's fairly straightforward. So when we interviewed patients and clinicians, the patients thought it was very convenient. They really liked the idea of not having to go to a GP surgery and be coughed upon by people while they're waiting at their blood pressure check. They had a perception that their care was better. They got a free BP machine, which was very nice as well. So the clinicians were impressed by the strong evidence base. They really liked the way this fitted in with the systems that they already use. And there were these clinical champions who blazed the trail. And it's actually quite important whenever you're saying, well, Dr. X in X practice has got 350 people signed up to the system. And as soon as anyone hears that, they suddenly realize, well, this isn't just a toy, this is something that works. So several of these practices now have almost a third of their patients being managed this way. Right. So using the routinely acquired data to actually measure this allows anonymized comparator data. We can use the BPs from the monitoring system, BP medication test results work with the GP systems. They all can be taken down from routinely acquired data, hospital attendances, major diagnoses, this type of thing. And so we're able to actually see whether this is working or not. There are some challenges here because home measured blood pressures are different from those measured in the surgeries. And even looking at changes can be difficult in the surgery because we find that the GPs were tending to type in the average blood pressure in as if the patient had been in the surgery. So it was actually quite difficult to compare. So this is a diagram showing everybody that was in this system at the start and how it changed over time. And as you can see, there were people who were really quite high at the start there on the left-hand side, gradually coming down over time, and some people who were over-treated gradually starting to have their blood pressure rise. Okay? And if you look at the proportion of people whose systolic BP values were greater than 150, so at the start, you had around about 15% of people were very badly controlled, and this went down to less than 2%. And the proportion of values now greater than 135, so these are people whose blood pressures are not as well controlled as you'd like, but they're not desperately badly controlled. One of the problems we have with these systems is you get people who have got a blood pressure of 136 or something like that, or 137, so they're still getting messages saying your blood pressure is poorly controlled. But if they're on 3 drugs, no one's going to give them a 4th drug to make them 134. Although the renal physician in the audience would probably disagree. Right, so the main highlights was the mean difference from the first blood pressure readings and the last readings, 4.8 millimeters in the first 6 months, and that increased to 9.2 in people who'd been on it 12 months or more. And likewise for diastolic readings, matched control cohort over that time showed no change in blood pressure. Changes occurred regardless of age, sex, or social deprivation. Medication use increased in people who had uncontrolled blood pressure and dropped slightly in people whose blood pressure was initially low. Face-to-face appointments fell a bit, and that really surprised us because we thought when we introduced this system, like all new things, that this would increase face-to-face appointments. We're not too sure about this because this is not a randomized control trial, and it could just be something completely different. In other words, it's just really hard to get an appointment with your doctor at the moment, and it could be as simple as that. So we don't know. So we're continuing to analyze this, and the good thing about routinely acquired data is you can very cheaply continue to follow this. So 5 years from now, we'll be able to follow these people and see what's happened to that too. So limitations of this is that these comparators are not strictly comparable maybe because maybe certain people who use these sort of devices are more enthusiastic, more keen to look after their health. So it can be difficult to do that. In the future plans, we're hoping to link with this is one of the NHS patient portals, either with like Patient View or also or My Way, which is the diabetes one. Either of those would be fine. We roll this out Scotland-wide. We just got a large amount of money from the Tech Fund, and we roll this out to several areas of Scotland now. And we were hoping to do some sort of large-scale evaluation, maybe actually see if there was an impact on strokes, heart, and kidney disease. Quite hard to do that. You need very many thousands of people taking part before you can do that. And that's it. Thank you very much.